Hey, welcome everybody to Stethoscope, Hawaii Medical Association's News Hour. We're here filming at Hawaii Medical Association headquarters in beautiful downtown Honolulu. And we have a very interesting topic today, hot as can be, and that is medical cannabis. And especially as it relates to these new dispensaries that we're finally able to have here in our state. So we have a very distinguished group of people here to comment on this. I've got Christopher Garth with the Hawaii Dispensary Alliance, the Hawaii group of dispensaries that are banding together to make sure this whole thing comes off without a hitch and in a very safe way. We have Christopher Flanders, Executive Director of Hawaii Medical Association. Dr. Flanders also served on the Medical Marijuana Advisory Task Force recently put together. Our third commentator today is Dr. Clifton Otto. He is a board-certified ophthalmologist here in Honolulu, a graduate of New York Medical College, and also served on the Medical Marijuana Advisory Task Force recently set up here that was a guide group to establishing the rules and regulations for dispensing here. Welcome, sir.
Thank you, Scott. Nice to see you.
Now, the Hawaii Medical Association understands that medical cannabis is here. Doctors have been referring for certification cards for a number of years here, ever since it was legalized. To that end, however, with the new dispensaries coming up, we thought it would be a good idea to take a step back, understanding that medical cannabis is here. It is a therapeutic tool that is helping a lot of people already, either in the area of pain, some glaucoma treatment. We've got a number of other indications for it, and people are benefiting. That said, we also understand as doctors that any therapeutic tool that is effective can cut the opposite direction of a positive benefit, and you can have negative side effects and difficulties. I think the experience in Colorado has borne that out. We've got an increased number of visits to the emergency room, particularly for people that visit the state and try the edibles. They don't think they're getting enough maybe at first and eat more and can end up in the emergency room. And so we want to talk about that. But one of my goals here in this show is to go over the 14 recommendations that Hawaii Medical Association made for safe dispensing and common sense dispensing. So we're gonna package this show up in addressing those different issues. Christopher Garth, give us a little background, if you would, about how you became involved in this issue. I know you have a political science background, but how about a little history about the Dispensary Alliance, and bring us maybe up to the present time in terms of recent history of bringing dispensaries to reality.
Sure, not a problem. We are the trade association for the entire industry. So we have a network of doctors, of lawyers, of CPAs, of architects, of engineers, of growers, of patients, of dispensary owners and operators, and then those that were even unfortunately not able to receive the licenses in this round that are dues-paying members to our nonprofit. It's a 501c6 organization. So we do have a legislative and government relations arm to what we do, but we're also very much embedded into the community and public information and industrial education about how this is a benefit to the people of Hawaii. We're trying to make sure that the rollout is appropriate and safe for any future steps that this dispensary program will take on in the near or far future.
So you're more than just a trade association, you're interested in the safety side as well. That's my understanding.
Absolutely.
As I understand, you reached out to us to see if you can work with the Hawaii Medical Association and or other groups in making sure that the public is protected.
That's absolutely correct. We're more than just protecting the interests of the dispensaries, and we feel that in order for the industrial complex of the medical marijuana dispensary to be solvent and viable, there has to be cooperation from all tiers of society that will be engaging with this new rollout. And that's going to be everything from the dispensaries themselves to the patients and everyone in between, which of course includes a group like the Hawaii Medical Association. We, of course, provided language to execute a memorandum of understanding so that we could work towards executing a number of the 14 points that you have, but that unified front across all sectors of the economy and society are really what move this forward in the right way. So that's our goal. That's where we are. Safety first, exactly.
The best policy. Dr. Otto, maybe a little background, your background. We know you're an ophthalmologist. I also understand that you do, to some extent, provide certification for safe cannabis medical use. What happened in your background and your history that led you to this point in time?
Well, my interest in this area started because of a family friend who had colon cancer. And I got to see firsthand how he went through using cannabis medically to reduce his nausea and pain while he was undergoing chemo reduction before surgery. Immediately after surgery and following surgery, he needed a second round of chemotherapy reduction. So I was able to see firsthand how he was able to benefit from this. And then I started doing a little bit of research on my own because, as you know, when we went through medical school, there was absolutely zero information conveyed on the endocannabinoid system. So I knew nothing about it from a medical point of view. Started doing my own research and was amazed by how much literature is actually out there from the 70s, from other countries that are starting to pick up the research, and then started to look into it from a legal point of view. And that's when I really started to get a little upset at how the legal system was actually hurting our patients, and started to become an advocate for improving the program, trying to get the program moved from PSD over to Department of Health. And it was around that time that the Department of Health asked me to join the dispensary task force in 2015. So I was able to see that entire political process, which was quite enlightening. And I also held off on doing written certifications for about 2 or 3 years, thinking that by doing certifications I might put myself into that group of so-called pot docs, and I might not get as much respect at the legislative level. Unfortunately, whenever you start talking about marijuana at the state capitol, a lot of doors start shutting. And so I had so many patients coming to me, cancer patients, seizure patients, glaucoma patients, because none of their doctors would fulfill that need. And I finally just started doing it. And I'm glad I did, recognizing that we are not recommending this substance. All I'm doing and certifying doctors are doing is providing a written certification in compliance with state law. And then I follow that up with close supervision and education on how to use this material safely and effectively, which is, part of that doctor-patient relationship that we're probably going to be talking about in a little bit. So that's really my history in the area, and I continue to be active and try and advocate for our patients.
Yeah, I think that's great, and we want to find out more about your experience, but also I want to turn to Christopher Flanders right now, Executive Director for Hawaii Medical Association. Dr. Flanders, you served on this medical advisory task force, did you not?
I did.
Would you share a little bit about what that process was and who some of the players were at the table and how that led us to a point where we actually have these dispensaries?
So this was a group that was put together in part by the legislature, in part by the Department of Health, because they were taking over the medical marijuana program from Department of Public Safety. And it was comprised of a vast myriad of groups. There was legislators involved, there was the Department of Public Safety, law enforcement, there were attorneys, there were physicians, there were patients, there were caregivers, the whole range. And just to discuss what a dispensary network might look like, and what the concerns were, what the advantages were of setting those up, and what precautions we needed to take as a public health measure to follow through with those if that's what we decided to do, and then report back to the legislature at the start of the next session.
What were the big issues that came up in that process that stand out in your mind?
So obviously one of the bigger issues was protection of minors from use, either inadvertent or or clandestine use. So we spent a lot of time talking about that, and that took us into other areas to talk about the safety of having edible materials containing cannabis, whether that was going to present a problem or a safety issue. We talked about the issues, the legal issues that, it's because marijuana still is illegal as a federal law, and how as a state we can maneuver or work our way around that. The state attorney general was on there and was able to provide some guidance in that regard. We talked about other issues. Our concerns, of course, were safety of patients and what we can do to make sure that the product that they're procuring is safe and that they're not going to be endangered by use as little as possible. So it was those kind of things that drove the committee. The patients were able to give their personal experience and guidance as to how a program might work best for them, and so that and really they carried quite a bit of weight in the task force.
Well, it certainly were, because we're here now talking about this. What I want to do is we're going to go through the recommendations for safe cannabis dispensing and utilization as put forth by the Hawaii Medical Association, and we're going to do this in a packaged way for those of you who are watching that don't have a lot of time to sit through an entire presentation. So let's get going. Recommendation number 1, ensure product purity and quantifiable potency. Maybe Mr. Garth, you want to talk a little bit about that and what's the latest on what the dispensaries will be doing?
Sure. So right now, everybody is scrambling to secure their facilities. These are their grow facilities, and then beyond that, looking to get their organic material.
I'm sorry, sir, how many licenses went out?
There were 8 licenses, and each license provides for the opportunity of 2 grow facilities and 2 retail facilities. And there will be no diversion from those facilities or exchange with other licensees. It's a vertically integrated market, so if you're going to sell, you have to grow. If you're going to grow, you have to sell. Each one of these licensees will be responsible for obtaining their own material, and then, of course, before they can sell it, it has to be tested and certified by a state-certified laboratory. And our conversation with the Department of Health Lab Division provides that no one has yet, as of, well, today is D-Day, so June 7th, 2016, no one has filed the paperwork to be that lab. If there had been one, we would certainly know by now, but of course the certification will not be limited to a single lab. There'll be as many as qualify. So we know that in some capacity there are rules and requirements that dictate what kind of contaminants will be in there, what the acceptable levels will be, and then of course when it comes to the potency, those will all be determined, and then even beyond that, the genetic makeup and the names of each strain will be available as well.
Very good. I understand Colorado had some problems with this. For anyone here at this table had know much about that. I just that the amount of THC in a particular product was in question as to what was printed, and so on and so forth. Of course, we want to avoid that here.
Yeah, it wasn't just Colorado. I think every group has issues, and that's why you have a primary examination of the product at the dispensary, and then you have it qualified and certified by someone at the state. It's just like getting a second opinion.
The fact that we don't have a lab that stepped forward at this time, is that going to slow up this process?
Not necessarily. Most of the groups are still in the beginning stages of construction to erect their grow facilities. And then beyond that, they still need to apply and qualify for their NED certification to host this illicit material. Only then will they be able to start growing. So having a lab is not necessarily the first concern. It's further on down the list, I think. Can we all agree on that?
Well, I would just add a couple of things to that. One is there's no national accreditation process for labs that are doing cannabinoid analysis. Americans for Safe Access is trying to come forward with a program using a national accreditation agency to start accrediting labs. But that process itself is probably about a $30,000 one-year process to become accredited, which is very different than certification. Certification you can just make up and have certain regulations that a lab needs to follow. So there's that piece, and if the state is going to require accreditation, that's going to delay things. But the other part is that the state is requiring analysis of all these different pesticides. I think 15 different pesticides and perhaps even heavy metals, which are really not necessary for initial testing. And we've proposed 6 different surrogate tests that would pick up about 90–95% of all contaminants and drastically reduce the cost of chemical analysis, which is going to be a potential limiting factor for the dispensaries.
Is contamination of product a big real thing, or a possible thing, or a boogeyman that doesn't exist? What do you think?
It depends on how the system is set up. Looking at the contaminants afterwards is kind of an afterthought, and a lot of this could be taken care of by putting in organic processes at the very beginning and a state certification process along the lines of the USDA organic certification to make sure that labs are following these processes with random unannounced spot checks. That would be the way to pick up any abuse, rather than waiting till the end and then testing and trying to figure out. If you could get it up front, then you wouldn't need all this fancy testing.
Recommendation number 2, avoid edibles resembling candy, cookies, and other child-oriented food items. What do you folks know about that? Well, are we building in some safeguards here, or anyone?
Yeah, Dr. Flanders.
Yeah, that was something that came out of the task force, and it was one of our primary concerns about protecting the children, that children don't inadvertently see something that looks like gummy bears, for example. It's really, grandpa's medicine.
I've seen gummy bears. I've seen them in Colorado when I was out.
Yeah. And if you go through dispensaries in other states, you see these things, and they're kind of concerning. So the idea was to discourage inadvertent consumption by kids, and offer that protection.
Well, here we are. There's a plate of cookies, or a box of cookies on this table. There's a box of cookies in the kitchen here. Adults still eat candy. They still eat cookies. They still eat sweets. I mean,
we should be protecting adults too.
Say that candies and sweets are only for children is kind of a farce, right? Of course, this should be more adapted to gun laws. Don't leave your medication out. There should, keep it out of reach of a child. Use common sense. Of course, common sense isn't often...
It's not very common.
Yeah, it's not very common, unfortunately. And especially when you're talking about something that can lead to a heightened state of inebriation, you're even less apt to indulge in common sense. But to provide that this should be a qualification for edibles, or even to exempt edibles because they are going to be directed, assuming that they're only going to be directed towards children, is too much of a stretch, I feel. And in some cases, adults might not be able to take medicine, in this type of medicine, in traditional forms, where a gummy might be the most appropriate form. So why are we keeping this form of medication?
Yeah, well, I think they are allowing lozenges and those kind of things.
Lozenges are available.
So, yeah, and nobody wants to encourage people to smoke marijuana. So
Indeed.
That's one of the gray areas that we worked around.
Now, unless it's the only way it works for them. I mean,
correct.
You can show that
there's also in nebulized or vape form that provides the same sort of satisfaction or relief. Now, there is an opportunity for edibles to be introduced in a safe way, and a safe and appropriate way, so that it is not necessarily directed towards children, and that can be through the packaging, right? But to say that the form is inappropriate because it's something that children might like is wildly inaccurate.
You know, and I think and a lot of these things are going to change as the process goes on. We're, you know, operating out in a dark room at this point.
That's
and
true.
As the light starts to shine, will change.
And I think part of the reason we're in that dark room is, to my knowledge, we're not asking the patients what they want, what would work best for them. And we have an incredible resource with the Department of Health database, because in order to be certified and registered, you need to have an email address. So the Department of Health has email addresses for all 13,000 patients.
We to 14, gaining on 15. So yeah,
even better.
What you're saying, this is a potential research tool?
Well, we
Is that what you're saying?
A confidential, consented survey of our patients and find out what they need and what works best for them. And I would think that information would be very helpful for dispensary owners.
I like that idea.
the
yeah.
converse, or the supplement to what Dr. Otto is providing is that doctors should be providing these certifications, and in that genuine relationship they should continue the conversation with their patients to say, is this working? Just as Dr. Otto has provided. He's saying he follows up with the patients, he's making sure that it's working for them, that they're trying whatever works in whatever form to the best of their ability, and he's not giving them the medicine, he's just simply directing them, providing them with the certification. If every other doctor has the right to provide these certifications in the state of Hawaii, if every other doctor took the same due diligence and care with their own patients and didn't farm them out to good doctors like Dr. Otto, who are doing great work, but if they do their due diligence with their own patients, they could also be a resource. Every doctor at this table, everyone at this table except for me, could provide that same resource as to how are we being effective? Are we being effective? How could we be more effective?
Yeah, I think we all form clinical impressions, those of us that do, as I think we talked before going on camera here. I don't personally provide certification, but I refer to doctors like Dr. Otto for that as kind of a specialty area. But we have an injury recovery center, a Workstar Injury Recovery Center, and I found medical cannabis to be effective in some, not all, patients in the areas of sleep, pain, anxiety, depression, and constipation. So I'm quite interested in that area, because I'm always looking, particularly in the pain area, where with all of the conflict and problems coming in with opiate use and overuse. Good doctors everywhere, I think, are looking for a substitute medication for opioids that is effective as an opioid, and in some cases, some of my patients find it to be superior. So, but I got to keep moving on this list.
Sorry,
okay,
thank you.
Number 3, encourage use of naturally grown products versus extreme potency extractions such as shatter, wax, honey oil. What else? Panel. I see people with vape pens. I see people, but just to speak to extractions versus naturally grown products, we at Hawaii Medical Association thought it was best to stick to organics, particularly coming out of the shoots. Everything is open to discussion here.
Well, I was going to say, simply this gets back to patient safety, that one of the larger groups that have certified into the medical marijuana program are seniors who were around in the 60s and 70s when recreational use was pretty common. But the marijuana of today is not the marijuana of yesterday by any stretch. And
even natural marijuana is much more
right.
potent. That's what.
Right.
Yeah.
And what's happened in other states, what's been demonstrated is that people get into trouble with too much, that it's too strong, and for THC naive patients, they can react in peculiar ways.
Earlier in the program, we discussed how no one is advocating for smoking, right? And the vape pen is one of the ways to circumvent smoking. But it comes from an extract. So to say only natural products is implying that you only want people to smoke the raw flower or imbibe the raw flower, and it's a little bit of talking out of both sides of your mouth right there. I think that when we look at the shatter, the wax, the honey oil, at this point, there's not necessarily medical benefit. It hasn't been tested. and
that I think is our HMA's position is
Exactly.
because we need more research, and we're going to get into the research that is known, and I know you folks are more up to speed than I am, particularly with respect to the Israel data. But the concept of low and slow was saying, hey, since we don't have a lot of good clinical research yet, for a number of reasons. First of all, it is still illegal on a federal level, and it can't be studied, which is very unfortunate, speaking as a doctor, in my opinion. But to go low and slow is just, once again, common sense.
Absolutely.
I just wanted to comment on number 3. I think that extracts have a really significant place within medical use, because there is a segment of our patients, especially our cancer patients, that are going to need the strongest material available in terms of THC and CBD content because of the proven anti-cancer properties of these chemicals. Some of these patients are taking up to 1 gram a day of a concentrated alcohol or CO2 extraction. And I think that we need to protect that.
To be clinically effective, you're saying a concentrate might be the only thing that works for a certain patient?
There are 2 approaches. You know, you want to find the smallest dose that it has the greatest efficacy. And so you can do that with flowers for certain conditions, but when you get into other conditions like seizure disorders and cancer, you need higher doses of these substances. And it's difficult for the patient to get enough of this substance just by inhaling a dried flower. And they might not be able to inhale. They might have a G-tube. The chemicals need to be put into a preparation that can be taken in concentrated form. So I would say, even though if gotten into the wrong hands, there might be a higher abuse potential for some of these honey oils, we need to make sure that those preparations are available to our patients. And that's going to be the challenge for the dispensaries, because making these concentrates requires a lot of material, and the patients are not going to be able to afford it at $100 a gram.
Dr. Otto, you, after I introduced you in your kind of opening statement here, you used a big word. I think we probably ought to clarify a little bit for our audience, and that is the endocannabinol system of the brain, or the receptors in the brain. Could you go into that in a little more detail?
Well,
what's going on with that?
The endocannabinoid system is probably the most prevalent receptor system in the human nervous system, and something we knew nothing about, because it took the discovery of the chemical structure of THC back in the 60s, and then looking for the receptors that allowed for the mechanism of action of that chemical, and then discovering the natural endocannabinoids that our body makes on a regular basis, to be able to understand that these receptors, the way that they can inhibit nerve transmission, actually allows for a reestablishment of homeostasis in the human organism. And it's something that we've evolved with and is present in many different organisms. So an understanding of the endocannabinoid system and how prevalent it is essential to understanding all of the different uses that this substance has.
And what is this saying, that man evolved with cannabis, or utilizing cannabis? Is that the
Well, it's been around for at least 3,000 years. Mm-hmm. And so some people feel that we have kind of co-evolved together, with the humans protecting the plant because of the benefit that they receive.
Fascinating. Okay, where smoking or vaping is a preferred method of delivery, perform regular medical surveillance with pulmonary function evaluations and regular checkups. Anyone have a problem with that?
I'm all on board for that, and I think that goes back to market research, basically.
That's just good medicine.
It is.
Right.
Yeah.
And
That's part of the
Physician-patient relationship would require that they follow up on that, just out of the practice of medicine.
I would just add, as a medical organization, you might want to consider not even promoting the idea of smoking, because I think there is enough good quality vaporizers out there now that you could say, if you want to do inhalation, please move away from smoking.
Why, doctor, do you think vaping is safer than smoking? What's the clinical
because
rationale?
you're not heating the substance to the point of combustion. You're heating it to 375 to 400 degrees, where you're allowing the volatile chemicals to go into a vapor form in the air. And so they can be inhaled without all of the carcinogenic byproducts of combustion of plant material.
The high temperature combustion creates more carcinogens, and therefore you kind of sidestep that risk?
You eliminate all of the carcinogens completely. So it also improves the efficiency of that route of administration, because you don't inhale and exhale immediately. You can actually hold the vapor and increase the amount that's absorbed in the lungs. So there are certain patients who feel that the effect is more of what they're used to from smoking, because you got a little bit of carbon monoxide in there. The effect is a little faster. They're maybe more familiar with that. But I would say that a lot of patients, if they were educated on how to use a vaporizer and how to adjust their dose to use a vaporizer instead of a joint, that they would find that it's not only effective, but more convenient. You don't have the smell that you do from burning marijuana. Easier to keep away from the kids, easier to keep private.
And you've been certifying for medical cannabis for how many numbers of patients have you been involved in that utilize medical cannabis?
Well, I'm not really out there pushing myself as a certifying physician. I kind of let the patients find their way to me. And I do a couple of patients a week on Fridays. I have a private office completely separate from my retina practice, because I like to keep the two completely independent.
You have over 100 patient experience, would you say? I just was wondering about your clinical.
That's pretty accurate.
All right, well that gets to be significant, so I'm listening. All right, number 5, develop mandatory informed consent forms outlining the risk of cannabis use as a prerequisite at dispensary sites. This should include clear warnings that cannabis should not be used when driving motorized vehicles, working around heavy machinery, or any other high-risk environments. Any debate or discussion in that area?
No, I think that's appropriate. I mean, just as there are warning labels on opioids and even alcohol, I think that this is probably, again, one of those common sense scenarios that should be incorporated as this industry develops.
Again, it fits into the medical model. That constitutes informed consent, or a portion of informed consent.
Next one, ensure a smooth and efficient mechanism for reporting adverse effects of locally dispensed cannabis products and preparation. That plays, we already discussed this a little bit, that we've got to, since we're finally tracking all the folks that are using medical cannabis through the Department of Health, we've got an opportunity to keep our eye on this for both the negative side effects as well as positive. And I think I'm quite excited about the potential of this as being an effective clinical research tool. If we do it right, is the will there at the Department of Health? Either those of you interact with them more. Dr. Flanders.
So that was a topic that came up quite often in my discussions with task force members, and especially a couple of the legislators, that we take this opportunity to do clinical studies and find effectiveness parameters and those kind of things. That's the piece as a physician and as a scientist, I think, that bothers physicians the most, is that the data's not there, that there's really no solid data that we have that's generated in this country that we can rely on.
I think you're right, Dr. Flanders. I also think there's a lot of concern that we're on a track basically to legalize for recreational use, and that the medical utilization is just a necessary but hopefully abbreviated stepping stone to that process, and that the whole process is commercially driven primarily, and that the public safety will be cast aside.
When it comes to patient safety and customer complaints, being the voice of the industry, we will host a complaints section on our website to ensure that any complaints, either personnel related or product related, will be conveyed publicly and of course submitted to the Department of Health. So acting as, of course, an industry watchdog, if you will.
Very good. And that's why we want to get this dialogue going and really work together, both the medical association as well as your trade association, to make sure that the public is protected. Sure. Next number, support the development of ongoing CME opportunities for local medical professionals and dispensary personnel on the preparations and types, current research findings, up-to-date public health impact, experience of other states, etc. That what we're promoting here is the collaboration between dispensary personnel and the medical community to make sure, for instance, you know, once a card is given and the patient has access to these dispensaries, I can't think of better people to watch out for danger signs. Maybe people that are going off the rails a little bit, incoherent when they come in and so forth. I think dispensary personnel have an ability here to help monitor in this way.
Well, and
Dr. Hotto.
When you talk about continuing medical education, there's a huge need for all of our physicians because of how little education we've gotten in this area. I'm hoping that this is something that HMA is going to push forward. I recently went to a conference in San Rafael held by an organization called United Patients Group. And they're one such organization that's providing CME level education with doctors who are experts in the field who are giving lectures to doctors and nurses. I think that's key for medical professionals because we need that CME in order to maintain our medical license. And if we could tie that education to formal CME training, I think there'd be more of a motivation for doctors to get involved. Also, perhaps there would be a role for requiring that doctors take a 3-hour CME course if they want to write written certifications. So at least they have demonstrated a certain knowledge and proficiency in this area.
Anybody on the state side that is taking a lead in this area, do you folks know? Why not us? Why not Hawaii?
I think it would be great if HMA took that on. I know that there is a mandate for Department of Health to provide education, but they don't have the resources, they don't have the funding or the staffing. So I think it's really going to fall to the medical community to make this happen.
Well, gentlemen, if you will, that is one of the operating components of the Hawaii Dispensary Alliance. In our I should say, I can't say our bylaws, but in our mission statement, and even detailed in our budget, we have money set aside to provide continued medical education programs for the state at large. And of course, the MOU that we have with you, or that we're working on to execute with HMA, and one that we have with Drug Policy Forum Hawaii, will and should provide these CME opportunities, and then beyond that, CNE opportunities, and then further CLE, which is continued legal education, so that everyone can be on the same page as we move this industry forward, as we move Hawaii forward for the next steps. Consider this, we have reciprocation coming in 2018. We need to be ready for that, which ultimately means that we'll be able to receive medical patients from other states or perhaps even other nations. But everybody needs...
Initially not, the way things are set up right now.
To residents or resident patients up until 2018. But when 2018 comes about, it's all systems go. And when it comes to the honey oil or the shatter or the wax, when it comes to common sense practices, continued medical education, continued legal education or nursing education, all of these things, we need to be all on the same page. We need to invest in our future to protect our future, which is ultimately why we're here having this conversation.
Exactly. Next one, ensure that an ongoing medical relationship with a regular follow-up, a doctor that can provide regular follow-up, be maintained at all times while a patient is utilizing this for medical purposes. That just makes sense to those of us in the medical community. Understanding that the patient will be able to operate pretty much autonomously. As with any therapeutic agent, particularly something that does have some downside risk, we're feeling strongly about that one. Dr. Otta, you provide follow-up, do you not, for your patients?
Well, yes, and
You don't
that
just write the certify them and then see you down the road?
Well, that's the requirement of a doctor-patient relationship, that you have ongoing follow-up with the patient. And that could be either through face-to-face visits, it could be through phone calls, through emails, whatever allows the patient to communicate back how they're doing and any problems they might be having. But this also speaks back to that previous point where you're talking about having a Hawaii authoritative body oversee these physicians who are doing certifications. That's something that could potentially rest with the Hawaii Medical Board, because the California Medical Board has come out with very clear guidelines on how to do a certification and how to maintain the doctor-patient relationship. Unfortunately, our board is not really interested, or perhaps doesn't feel it's within their mission to provide that, because they think that they would only address that issue if a complaint were brought against the doctor. So again, there's a void there that perhaps HMA could fill to put forward formal guidelines. And these recommendations are certainly a start, but specific guidelines on what is the doctor-patient relationship, what should that examination include, what are the different pieces to ensure that that's happening. And then, of course, we have the Hawaii Medical Board in case something happens and a patient is not being treated properly.
And you and I have a common mind on this, by the way. You know, Hawaii Medical Association has a built-in peer review process for its members. So what I'm advocating, and I actually have that in one of our recommendations here, is that the doctors that are involved in this process should be members of HMA, so that they can be subject to some peer review. But if not us, then at least a hospital or another authoritative body that provides peer review to keep the public safe.
Sure.
So that, you know, you're talking about just being a pot doc and how that kind of has a negative connotation. I think we want our medical community to develop a higher level of professional standards, as I know you're following yourself. But we don't want this to be some kind of mecca where fly-by-night physicians come here just for the idea of setting up a kind of a mill type of an operation.
And I think the CME education would help with that. But on the flip side, you also have the confidentiality of the doctor-patient relationship. And so that's something that we also have to be careful not to encroach on.
Let's keep going here because we're running out of film and we're running out of time. Deb, here's one, might be a little controversial, but I know some of the applicants did include this in their package. Dedicate a % of gross revenues generated to promote the reclassification of cannabis and to provide for CME activities and so forth. What do you know about that, Chris Garza?
Well, as the Chief Government Relations Official for the Hawaii Dispensary Alliance, I think that it makes sense for all of these groups to move forward in unity to reschedule at the state level, at the national level. Whether or not it should be something that they should contribute to HMA to do such is certainly up to them. I do feel, though, that it is important that we get this rescheduled at both levels so that we can operate as individuals or as medical professionals or as legal professionals, as business owners, without fear of any kind of legal penalty. And then further, the medical community really needs to have marijuana rescheduled from a 1 to at least a 3 so that research can be conducted on any of the benefits or even the pitfalls of use.
I think you're preaching to the choir. Dr. Otto, were you going to jump in on that?
Well, I would say that you really wouldn't need dispensaries to contribute to efforts to reschedule if the state were doing its job. And the reason we have this program is because the state has the authority to accept the medical use of controlled substances. They did that in 2000. The next step is you got to tell the DEA, look, federal law says that if marijuana has accepted medical use, it can't be in Schedule 1, and get them to follow federal law. Everybody says federal law trumps state law. Well, if you look at federal law, it says can't be in Schedule 1 if you have accepted medical use. But I would say it would be more constructive not to say which schedule it should be in. We should just be saying it doesn't belong in Schedule 1. If you look at the state level, the state says it has the highest degree of danger. Well, we don't give substances with the highest degree of danger to our patients. There is no substance in state Schedule 1 that we give to our patients for medical use. So we first need to look at it at the state level and get the state to do its house cleaning and put it in a schedule that makes sense, because we got the coca plant and we got the poppy plant in Schedule 2. So that would be the first step, and then go ahead and tell the DEA that they need to recognize state accepted medical use. But I would stay away from picking a certain schedule for it to go into. At the state level, the Public Safety Department is required to make scheduling recommendations every year to the legislature. That's their authority, and of course the legislature makes the final decision. So it would be very appropriate for public safety to say, to do their analysis and make a recommendation on what schedule it should go into. Similarly for the DEA, they make a decision in consultation with the FDA and decide what schedule it should be in, and that's their area of expertise, along with public hearings.
Speaking of regulation and oversight, there is a website you can go to that shows what other medicines people are using, what they're getting from other dispensaries, actually pharmaceutical dispensaries. That is very much important in utilizing narcotics. We are recommending that that be incorporated into this process in some way, shape, or form. Your thoughts, gentlemen? It's called the PDMP, the Pharmaceutical and Drug Monitoring Program.
I wonder, is that appropriate? I mean, considering there is no pharmaceutical track for marijuana simply because there are so many strains, there are so many ways to imbibe and then apply.
We got a problem because you don't know really what the person's using. And then that gets back to our point that we have to get this down to a better science with the amount that a person is taking, whether they're vaping or ingesting, and so forth. Now, I got to wrap it up here, but I want to leave the show here on actually a positive note, but it's also a word of warning, and that is with respect to edibles and eating cannabis products. Folks, unlike smoking, which only allows a certain level of the cannabis to be in your bloodstream because of the partial pressure of gas in the combusting or vaping, when you eat medical cannabis, you can't eat too much. The tendency is to not think it's doing anything because it comes on rather slowly, and to eat more, and then to basically OD and become toxic. I personally have had, because in my emergency medicine past, I have seen people really laid out and almost not in a full comatose state, but certainly almost catatonic and inebriated and dysfunctional. So there are dangers there. Be careful in utilizing it in that way, medicinally or recreationally. And with that, thanks for joining us on Stethoscope, and we'll see you next time. Aloha.